Acute ischemic stroke, considering all the factors. The association of factor V Leiden, or FVL mutation, with venous thromboembolic events, or TEs, is well recognized, but less so with arterial thrombosis. Furthermore, thrombophilia testing in the U.S. has translated to Medicare spending between $300 and $672 million, which necessitates cost-conscious care regarding thrombophilia testing. Here we present a case of a 46-year-old white male with the right MCA stroke found to have heterozygous FVL mutation after receiving appropriate thrombophilia testing. Our patient is a 46-year-old white male with a history of anxiety and a prior myocardial infarction, and a family history noticeable for his sister having a stroke in her 30s. The patient had left-sided weakness and facial droop, as well as decreased feeling in his left arm, which was confirmed on exam. Time of last known well was within the window for TPA administration. CT scan showed a right M1 occlusion, and MRI post-revascularization showed evidence of multiple acute infarcts present in the right MCA territory involving the inferior right basal ganglia and right frontal and temporal lobes. Echocardiogram with a bubble study was performed to evaluate for structural heart disease and the presence of a septal defect. The patient was found to have an EF of 48% and no evidence of septal defects that would allow for the development of paradoxical emboli. The image on the slide displays an image from the patient's MRI scan post-revascularization. The right hemisphere of the brain, pictured on the left of the image, shows areas of infarct in the inferior right basal ganglia and right frontal and temporal lobes corresponding to infarct of the MCA vascular territory. A hypercoagulability panel was ordered for concern of family history of stroke and lack of immediate cause of the patient's stroke. The patient was discharged before the results of the panel came back, but was found to be heterozygous for factor V Leiden mutation. Since no other contraindications were present, the patient was given TPA for ischemic stroke. Revascularization was performed with the TICI-3 grade, and the patient was admitted to the ICU where he was started on atorvastatin, aspirin, and prophylactic subcutaneous heparin. At discharge, the patient was referred to hematology to discuss the benefits of beginning anticoagulation therapy. FVL is a mutation that blunts the coagulation cascade's ability to self-regulate thrombin activation, leading to a 7-fold and 20 to 80-fold greater risk for venous thrombosis in heterozygous and homozygous patients respectively. Additionally, within the population with the TE, the mutation prevalence is 10 to 20%. The relationship between FVL and stroke remains controversial. Our patient had suffered 2 arterial thrombotic events at a relatively young age and lacked additional risk factors. Therefore, the decision to test for hypercoagulability was made. Anticoagulation therapy and recent TE disease affect results of thrombophilia testing. Heparin interacts with antithrombin, prevents protein C and S activation, and increases coagulation parameters. It causes inaccurate laboratory measurements of these proteins and distorts assays of lupus anticoagulant. During the acute phase of thrombosis, consumption of protein C, protein S, and antithrombin occurs, leading to unreliable measurements. Tests for factor V Leiden, prothrombin gene mutation, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies are not affected by anticoagulants or the acute phase of thrombosis, and therefore can be tested under these circumstances. And this is important because heterozygous FVL patients may have a higher risk of arterial thrombosis, even more so than homozygous individuals. Data regarding treatment is sparse, but published cases have been treated with antiplatelet therapy and high-intensity statins. In conclusion, for patients who experience unprovoked TE and TE events at a young age, conscientious inpatient thrombophilia testing reduces cost burden and increases the accuracy of diagnosis. And when it comes to arterial thrombosis risk, heterozygous FVL mutation may have more risk than homozygous mutation.